I am delighted to introduce today's speaker, our Clinical Director, Professor Nóirín Russell. The title of today's webinar is Empowering Sample Takers Using CervicalCheck Statistics to Inform the Consultation. Dr. Russell will be joined by our primary care clinical advisor, Dr. Sarah Fitzgibbon, no stranger to us all, who is going to highlight how the statistics inform all consultations with women about screening, explain the etiology of HPV infection, normalising high-risk HPV, reassuring women when referred to colposcopy. And this is really, this information can really enhance the care we give to women in order for them to choose screening. You will also have the opportunity to put faces to the names today of our primary care coordinator, lab coordinator, colposcopy coordinator, and our coordination executive of CervicalCheck, Maeve Waldron, is here today. And they will join as panelists at the end of the Q&A section of the webinar. So over to you, Professor Russell. Thank you.
Thanks, Rachel. Delighted to be here, and thank you so much for the invitation. The annual report, I appreciate it. It might not be at the top of your absolute priority list when you come back in a bank holiday Tuesday, so thank you so much for joining. This has been, I suppose, this has been really interesting report to prepare, because this is our first report based on the primary HPV screening programs. So it just took us a bit of time. It looks a bit different than the previous annual reports. It took us a bit of time to work out what we needed to report on, and hopefully I'll just find some of the facts and figures interesting. And then I was teasing Sarah will come along then and translate it into something more usable, because I have been accused of just being obsessed with it. So I appreciate the fact that Sarah is here to kind of make it all, I suppose, answer any questions and just see which nuggets are particularly helpful when you're talking to women about the data. Okay, so why do we have an annual report? Well, we have an annual report because we have quality. It's a quality assured program. We have 4 chapters in our quality assurance manual. So we've got quality assurance standards for program ops, primary care, and other clinical screening settings where we take screening samples. All of our laboratories, so both we've a chapter on our HPV, our screening laboratories, and histopathology laboratories, and we have a chapter on standards on colposcopy care. So the report essentially is reporting on the standards that we set to say how good are we doing against these standards. This slide always reminds me of sitting in a meeting very early on as a clinical director, and a patient advocate saying to me, "Well, who is CervicalCheck anyway? Who is it?" And this is, I think, this report is all of our report. I'm here today presenting it, but this is all of our report. So this report summarizes how we're doing against our standards and how we are doing in achieving the goal we set, which is to reduce the incidence of cervical cancer in the Irish population and to reduce death from cervical cancer. The report starts off with that exact chapter or introduction. So here's the data which is kindly reproduced from NCRI, which shows that we are continuing to see a decreased incidence of cervical cancer in the Irish population and decreasing mortality. These are statistically significant decreases. And this is a summary slide, just summarizing the key findings, the graphic, just the key findings. 73% of the eligible population are screened, etc. I'm going to go into that graphic in a bit more detail, so I'm not going to focus on it now. This is, I think, a very important slide, just again back to that purpose. So what does this program exist for? Why do we exist? Why are we all working in this area of cervical screening? And how do we know that we're following our purpose? So in colposcopy, every year, around 6,000 cases of high-grade CIN are diagnosed, and around 100 women are diagnosed with cervical cancer. We know, or we're conscious, that another 150 women are diagnosed with cervical cancer in other services, mainly in gynecology, but sometimes in emergency departments and other areas. But there's 100 women every year referred into colposcopy because of their screening result diagnosed with cervical cancer. And what we see from this, again, in an NCRI graph, is that women who attend for screening, 80% of the time, women who attend for screening, their cancers are diagnosed at stage 1. So women might say to you, well, could I get cancer after attending for screening? Yes, that is something that can happen. But there's an 80% chance that it will be diagnosed at stage 1 if you get cancer after screening. Whereas women who don't attend for screening, their chance of an early diagnosis is much lower, whereas only 1 in 3 women, or 34% of women, are diagnosed at stage 1. Another way of kind of summarizing that is of the 250 women per annum that are diagnosed with cervical cancer in Ireland, around 40% are screen detected. So they go for screening. This is the key. This is our key work. They go for screening. They have no symptoms, and they're detected with cervical cancer. Another 40% of cervical cancer cases are detected in women who are never screened. You're going to hear us talking a lot in the next couple of years about equity. That 40%, they're the women who don't attend for screening have a much higher risk of cervical cancer. And we are really working hard within the programme to try and understand what barriers women face, and what can we do to reduce those barriers to get women who never attend for screening to attend, because that reduces their risk of cervical cancer. Then there's another 20% of women who present with symptoms and they've had previous screening. Around half of those are interval cancers, and that means that they're diagnosed in the interval since their last normal smear. And around half of them, around 10% overall, are under-screened. So they've had screening of some type in the past, but they're overdue their repeat. So moving on to coverage, what do we find? So coverage, we have really high coverage in the Irish programme in our 25 to 29-year-olds. 87% of our young women are attending for screening. We can see the coverage stays high and it begins to decrease after 50. And we've been doing a lot of work with all of our stakeholders, just trying to, I suppose, get the message out that screening is for all women up to the age of 65. It's not just for younger women. And we know that we see a significant number of cancers in women over 50. So our 50 to 54-year-olds were up to 76%. This doesn't capture the recent project from last year, the age extension project, where we offered a one-off HPV to women over the age of 60, or between 60 and 65, who'd missed their HPV testing. But I'm hoping to see that coverage in the 60 to 65-year-olds will increase as the time passes since our move over to the age extension from 60 to 65. And just a reminder, this data is from the first 2 years of the programme, which is March 20 to March 22. But I think it's always nice to know, how do we compare internationally? So Ireland has got the fifth highest coverage in the OECD at 73%. The OECD average is 56%. And I think that's a tantamount to everyone in the team, all that work, especially in primary care, getting the message out to women. You're invited, you come for screening, it reduces your risk. It's a free test. So we have high coverage. We'd like it to be higher, but we have high coverage compared to other neighbouring countries in the OECD. And actually, a lot of countries are finding a reduction in take-up of cervical screening, and they're quite worried about it. There is geographical variation. I think this is interesting. You'll see the different counties. So a lot of counties are under 70% now. That is impacted by the fact that we extend from 60 to 65. But we're wondering what else is impacting. That's Carlow. I think that's got the highest coverage. So what happens in Carlow? How come their coverage is higher? And we're doing some geocoding of our data, so we'll have a better idea about why are some counties lower. Is it that there are more older women in those counties? Is it to do with socioeconomic groups? Is there some other reason? Why are we getting lower coverage in some areas than others? This is some data from the laboratory turnaround times. I think this is all the arrows and the graphs and the up and down. You could nearly imagine it as the impact on mood during the whole COVID pandemic as well. I think we all had these peaks and troughs, but we certainly saw, we introduced HPV primary screening in March 2020, and we paused the programme for 3 months the next day. It was just an incredible time. It's great to be talking about the COVID pandemic in the past, but it did certainly knock the programme into a state of flux. Then we came back after the pause, but we still had pandemic impacts. We had a shortage of reagents in the labs. We had social distancing in the laboratories, which impacted in their turnaround time. We had COVID sick leave, we had lockdowns and fluctuation in attendances, so women could come, then they couldn't come, and then they could come again. And just to make it all really interesting, we had 2 cyber attacks. The first HSE-wide, and then the second one in the Coombe laboratory, one of our screening laboratories. So serious. We moved from having turnaround times where results were coming back within 10 to 15 days, times where the results were much delayed, and back up again to our standard turnaround times. So what did that mean then for women? And you'll remember we were always trying to update the website about what was the turnaround time, when could women expect their results back. And interestingly, throughout the 2 years of the report, 6 in 10 women received their results within 4 weeks. 3 in 10 women, it took between 4 and 6 weeks, and 1 in 10 women, it took more than 6 weeks to get the results back. So I think that's really interesting. We do try and keep the website up to date. At the moment, our turnaround times are excellent. I think we're at around 98% of women are getting their results back within the 28 days. But it's just really interesting to think about that time and how it did impact on our getting results to women. This is not from the report, but I love this slide, so I'm just going to go through it really quickly if you can indulge me. So what do we know from HPV screening? We know for every 1,000 women we screen, 20 will have abnormal changes. The smear test or cytology. Oh, that's live. That's when you do live webinars. For every 1,000, so the smear test detected 15 out of the 20 abnormalities, and HPV testing detects 18 out of 20. So it's a better test. What is a positive HPV test? Well, first of all, most women will clear the virus within 12 to 18 months. That's the first message we're all used to giving now. A positive HPV means that an individual is at higher risk of developing abnormal cells, and persistent HPV infection over 15 to 20 years can lead to cancer. But what is a negative HPV test? And this is a message I think we're really trying to work hard at getting out. But a negative HPV test is a better indicator of low risk than a negative smear was. So it indicates that the woman is at low risk of high-grade CIN in the next 3 to 5 years, and it's significantly lower. The chance is significantly lower that she'll have high-grade abnormalities than when she had a negative smear test. So 1 in 1,000 women with a negative HPV test are going to have a high-grade CIN at 5 years versus 4.5 per 1,000 women with a negative smear test would have a high-grade CIN within 5 years. So that's what you can see. It's that. So we get a lot of questions. I'm so sure you get a lot of questions about why you're not looking at my cells. We're not looking at your cells because if you have a negative HPV test, then the chance of having high-grade CIN in 5 years is incredibly low. It's 1.2 per 1,000. Not zero, but incredibly low. And of course, as we all know, if symptoms develop, women should be investigated with diagnostic tests, and never ever should we do screening tests to reassure ourselves that a woman with symptoms is fine, that screening does not work. Screening tests do not work well for symptomatic women. And it's very important that women attend for screening even if they're vaccinated against HPV. So back to the results, HPV. So we can see we did 190,000 tests in 2020, the first year, and around 290 in the second year. So 2021 was incredibly busy when things opened up a bit. And around 1 in 12 women are HPV positive. That's how it turns out. And of those who are HPV positive, around 60%, 57, 58% are HPV positive with normal cytology. Around 1/3 are HPV positive with low-grade cytology. And around 8% of women are HPV positive with high-grade cytological abnormalities. So so we know our 1 in 8 women, so 12% of the population are HPV positive, and out of that, around 8% of those have got high-grade cytological abnormalities. What do we know about the follow-up of women who are HPV positive normal cytology? So those women who we've tested, they're HPV positive, we say come back in a year. Well, first of all, we know that around 88% of them come back within 15 months. That's great. But I do worry about the 12% that don't come back, because screening is not a single test, it's a process, and you need to do the follow through. You need to follow up all the recommendations to get the maximum benefit from screening. And we know of those women who come back for that second HPV test, 58% of them have persistent HPV. So 42% have cleared their HPV infection by 12 months. And of those with persistent HPV, 4% have high-grade cytological abnormalities. So these are the women, they were 12 months ago, they were HPV positive, cytology negative. When they come back for their repeat, there's a 4% chance that they will have high-grade cytological abnormalities, a 1 in 3 chance they'll have low-grade cytological abnormalities, and both of those will lead to them being referred in for colposcopy, so either 4 or 8 weeks. And we know, of course, in the Irish algorithm at present, anyone who has a second HPV positive, even if they have normal cytology, will get a colposcopy referral. So how likely is it that a woman with high-grade, with HPV positive, high-grade cytology will have high-grade CIN and biopsy? So how likely is that abnormal cytology result leads to a diagnosis of high-grade CIN? Around 77% of the time. So that's, I think, a really helpful for counselling. So when a woman is going into colposcopy, there's a 77% chance if she's going in with a high-grade cytology that she was going to have high-grade histology and needed treatment. So colposcopy appointments, it was a busy 2 years for colposcopy. And again, lots of fluctuation. But what we found is that, as predicted, there was a 40% increase in colposcopy referrals with the move to HPV screening. We knew that would happen because HPV detects 18 out of 20. Remember, we said it detects more of the abnormal cells. But the way it does that is it increases referrals into colposcopy, more low-grade referrals being sent in to get that increased detection. And we know that the primary, so we went from referring 5.7% of the population in year 1 to 6.2% of the population into colposcopy in year 2. So it's certainly been around every year, around 53,000 women attend for colposcopy. So 20,000, 25,000 for first visit, and nearly 28,000 for follow-up in year 2. So why are women? What are the results? What are the results that lead to referral for colposcopy? So new referrals, first referral. You can see that there was a big change in the screening results. So we had in year 1. Now remember, screening was paused, so that did impact on the referral reason. So in year 1 of the HPV program, nearly 40% of referrals were for clinical reasons, right? And we knew if that continued, that we would not have capacity for this increase in referrals from the screened population into colposcopy. So again, lots of work, lots of communication, working with our non-colp gynae colleagues, so working with the National Women and Infants Programme, lots of investment from NWIP in I suppose ambulatory gynae and other pathways for women with symptoms. And it just meant that we could make sure that we had colposcopy capacity for the women who screened positive, because they were the ones who most needed that colposcopy. And we knew that we would we moved down from being nearly 40% of the referrals being for clinical referrals down to 20%. And we know that we can see the high grade cytology is around 12% of the referrals, and low grade is the vast majority of the referrals. They're like nearly 60%, and persistent HPV coming in year 2 at around 10%. Okay, this is just again another way of looking at that. We just wanted to divide out, so the clinical indications. Well, you can see the non-urgent indications stayed pretty steady, 2,900 per year, but you'll see the urgent clinical indications, a significant reduction in the proportion and the overall number of urgent clinical referrals, and that made space for that huge increase. We went from abnormal screening tests being from 10,000 up to 20,000, and that we needed that space in colposcopy for those extra referrals. So we know that at colposcopy attendance, we're always very proud. The CervicalCheck program, our DNA rate at colposcopy clinics is consistently less than 10%, which is one of the lowest in the HSE. And we know that in these first 2 years of the program, despite all of the ups and downs, fluctuations, numbers, lab turnaround times, change time, COVID, etc., that consistently 7 in 10 women are seen within 8 weeks of referral to colposcopy. So well done to the colposcopy community. That was quite an achievement in all of the madness that was going on in the first 2 years of the program. Now, it's very important to I suppose, to acknowledge the work that's going on in public health, in the National Screening Service. They've done a lot of work with the Australian modelling experts, the Daffodil Centre, who were the first people. Australia were the first people to model for cervical cancer elimination. Ireland has announced our date for cervical cancer elimination in 2040. But I thought this was really important for our histology colleagues just to be able to see, well, what is the impact of changing to HPV screening been on biopsies? And we can see that we certainly have seen that increase. You see an increase in referrals to colposcopy. You'll see an increase in numbers of biopsies, and around 38% of visits to colposcopy end up in a biopsy in year 1, and that went up to nearly 50% of attendances at colposcopy leading to a biopsy in year 2. But there is some hope, so it's not an inevitable rise, because what we know from our modelling data, and this is the Daffodil Centre modelling data, is that if Ireland moved to the Australian model, which is genotyping all HPV positive cases and referring 16 and 18 to colposcopy first and repeating the HPV test for HPV other, or the UK model, which is retesting in 24 months rather than in 12 months, and only and allowing more time for the HPV infection to clear. If we did either of these things, we would significantly reduce the peak in attendance and the peak and the numbers of colposcopy numbers of colposcopies by 50% and also the number of biopsies by 50%. So this is something that we're looking at in 2024, just trying to work out what is the best way for us to, I suppose, to flatten the curve, to use that old lexicon. So we are aware that we need to model this, and we need to work out how best to make sure that the women who are going to benefit the most from a colposcopy referral get there, and that we don't send women unnecessarily. That causes anxiety. We don't want women having biopsies they don't need. And it's about just modelling what's the best way to achieve our goal, reduce the incidence of cervical cancer in the population. And that's what we're looking at. So again, a bit more about biopsies. Now, Eagle-Eyed Mary, who's on the call, pointed out very, very rightly that when I showed this data internally at our meeting last week, when I said, okay, we have 2/3 of our biopsies that we take are low-grade CIN, 1/3 are high-grade CIN, around 1 in 1,000 or 7 in 1,000, 1% lead to a diagnosis of cancer. There's a missing line in that table, and that's how many biopsies are normal. And I will have that in the next report. But I think it's important that we can see that of the histology results with abnormalities on them, it kind of goes 2/3 low grade, 1/3 high grade, and 1% cancer in the abnormal ones. And again, we're trying really hard. Screening is a balance between benefit and harm. We want to try and avoid the harm of overdiagnosis, overtreatment, false positive, false negatives, harmful physical and psychological effects of screening. And that's why our standards are in there. But we want to make sure, that women who are treated by excisional techniques like a LETS, that they have at least 90% of them have, on the first visit, will have CIN, and 85% of women treated by a LETS at any visit have CIN. So we don't have lots of negative LETS, because that would suggest that we're being over treating. And you can see that in both years. So we've in 2020, it's year 2 of the program, we're back up reaching the target. So we're making sure that the women who we do a LETS procedure on have high grades or have CIN in their treatment biopsy. Here again, you'll see, so of the women who attend colposcopy, what sorts of treatments? Around 75% have a LETS and excision treatment. A quarter, so 3/4 have LETS, 1/4 have ablation, 1% end up being referred for hysterectomy, and very small numbers referred also for cone biopsy and trachelectomy. Very important that we have referral pathways from each colposcopy clinic, each of the 15 clinics, to gynecology, to our general gynecology services for hysterectomy, and to gynae-oncology for cone biopsies, trachelectomy, or onward chemoradiation. This is a nice graphic from the report just showing that the majority of women attending colposcopy do not need a treatment. So of all of women who require treatment at any visit, 13.5% of women who attend colposcopy will require treatment at any visit, and only 6% of women are treated on the first visit. So again, if you have someone who's really nervous about going to colposcopy, there's a 90% plus chance she will not be treated on the first visit. It usually is a period of observation, maybe take a biopsy, but treatment at first visit is rare, and actually treatment overall is only 13.5% of patients. Is for any colposcopists in the audience. So how good are we? What's our positive predictive value of colposcopy for high-grade disease? So what that means is when we think a colposcopy that is high-grade, and we think our impression is high-grade, how often is that proven on the biopsy to be high-grade? What we can see is that so the quality standard of 65% was for this cytology program. We haven't an adjusted standard for HPV screening, but what all countries who've moved to HPV screening have reported is that the PPV of colposcopy has reduced in HPV screening. So things that we think look high grade are actually not high grade. We are overcalling it in the context of HPV screening. I suppose it's just really important to be aware of that. We'll often find this at MDT. So 6 in 10 of what the high grade colposcopy findings, 6 in 10 of those women are proven to have high grade CIN and biopsy. This is from an international paper from Germany, looking at the sensitivity, specificity, positive predictive value, and negative predictive value of colposcopy. And I think really, whenever we're doing any test, we should have this is how we should be counselling. Nothing we do is 100%. Colposcopy is no different than that. So sensitivity, we pick up 78% of abnormalities. Specificity, if we think at a negative test, it's 70% chance that it is. We should correctly identify negatives. And what that means, the bottom line, so really, is that there will be women who have a negative colposcopy and it will and we will not see a cancer. So 6 in 100 women with 6 in 100 women with cervical cancer had a normal or low grade colposcopy in this study. So 10 out of 167, and 6 in 1,000 normal colposcopies led later the woman developing cancer. So I think this is something, I suppose, a shout out to the colposcopy community. I really think we need to be counselling and integrating this kind of data into our colposcopy counselling. It's a great test, but like everything, there are limits to it. We won't see everything. We won't pick up everything. An interesting one, the referral value. For every 3 referrals to colposcopy, 1 woman will have high grade abnormality or cancer. That's what and we keep an eye on that figure, because if that moves up, then we are seeing more and more women to find a case of high grade disease, and we have to look at what we're doing. And our final chapter then is our quality improvement portfolio, which was which we put into the report this year for the first time. This is Gráinne Gleeson, our program manager, has really taken this in hand, and these are all our projects that we're trying to make the program better. I'll let you read about it because I'm conscious of time. And then I just wanted to call out, this is my conclusion as clinical director, and I'm just so proud to be part of this program. And this is our data. This is all of the work done by all of the partners. This is sample takers, screening laboratories, colposcopists, histology scientists and histopathologists, the staff in the program, the National Screening Service team who support our program, and every one of us are making a contribution to improving the health of our nation. And we are on the roadmap towards the elimination of cervical cancer in Ireland, making it a rare disease by 2040, getting the incidence down to less than 4 per 100,000. And I'm very, very proud of this report. I think it's an excellent, excellent report. And final thing, I want to acknowledge the help of there was so many people who helped get this over the line, but in particular, I want to call out Micheál O'Rourke and Tres Mooney from PEU, Maeve Waldron, who is always so helpful, reading has great, I suppose, memory, because she's been in the program since the beginning, and just always can sense check and say, look, what about that? Fiona Ness and Anya Carroll from Comms. Carol, my wonderful executive assistant, who kept on reminding me, you've got to get that report finished, you've got to get it out. Gráinne, who did a very similar job, saying, is that not finished yet? Everyone on the CervicalCheck SMT and every single member who is here on the call is our report. And then a final save the date. Our conference theme this year in 2024, save the date, 19th of October. And our theme is fostering partnerships, because screening is a process. It only works if every bit of the process works, and if everybody understands how all the different bits work together, we can be better and stronger, and we get to where we want to be. Thank you very, very much.
Thanks a million, Professor Russell. That was fantastic. That was certainly an awful lot of information that you brought us through there, and Rachel has put the link for the to the report in the chat there. And again, we would strongly encourage everybody, if you have the opportunity, and just to have a quick look through the document. Sometimes I know it's a little bit hard for me to read things online. If there's a particular page that tickles your fancy, maybe you might like to print it out and have a look at it. And we would be very interested in people's feedback. I imagine, Nóirín, you'd be very interested in people's feedback on the report, and if you find it a useful tool within your practice when you're chatting with patients, and again, like that, how it might be useful to you in the future. As Nóirín has pointed out, this is, it's the 2 years since we moved to HPV, so moving over from our cytology program. And this is the first time that we have Irish numbers, Irish data on what a program that is based on HPV, what it means for our population. And also, as we've been mentioning, and you've probably heard us talk about quite a lot, is our move towards elimination of cervical cancer, which is obviously pretty incredible to think that that can happen, all being well, within the next 16 years. And that is going to be a concerted effort from all of us. And as we watch the numbers, follow the data, that's really going to give us those indications of the places where we are not reaching, the areas that we need to cover, and the kind of topics that we really need to focus on in order to get to where So as I say, Nóirín has gone through it very comprehensively there, but there was just, I suppose there's just a couple of things in that I think might be useful for those of us taking samples, you know, within primary care, those of us dealing with the public, those of us who are involved in all of the different aspects of cervical screening and in the communication around that. So what I might do, hopefully, if this works for me, and I just have to move that out of the way for that to work there. So I suppose the main thing that I would be looking at is when somebody is coming in, she's coming in for her first test. And again, this is coming into the, you know, the CervicalCheck eligible population, somebody between the age of 25 and 65. She's coming in, and we can say to her with confidence from the information that has come from the report, this is the likely outcome for you. So you come to have your first test. The most likely thing is that 9 out of 10 people will have a HPV negative result. There will be 10.5 people who will have 10.5% of people who will have HPV positive result. But so you're saying to people, and while we know that this varies a little bit across the age ranges, and these are our average percentage across the entire population that has participated in screening, that is a 9 out of 10 chance basically that they will be HPV negative on this test. If we have a think about those HPV positive people, so that 1 in 10 person who comes into you who will be HPV positive, what does that mean then for her? So what we're looking at, we know that when somebody's HPV positive, then we progress to the cytology. So when her sample has a cytology test done, we know that 58% of those people who have tested HPV positive, when we go to do the cytology in the lab, their cytology is normal. And we'll be giving them the advice to return again in 12 months' time to see if the HPV is persistent or to see if it has cleared spontaneously. So if we go back to our 1 in 10 people being HPV positive, 6 out of 10 of those people will have cytology normal. So they will just need to come back again in 12 months' time. There will be around about 35% of those people who are HPV positive who will have low-grade changes seen on their cytology, and they will be referred for colposcopy. And Nóirín has mentioned that they would be, on average, 7 out of 10 of them will be seen within 8 weeks. So they will be a low-grade referral to colposcopy. We'll send through that referral, and they will be seen within 2 months. A very small proportion of the people who are HPV positive will have high-grade changes on their cytology. So 8% of the people who are HPV positive on their first test will have high-grade changes and will need referral to colposcopy, but will be seen on the slightly quicker trajectory. So should be seen within 1 month, because we know they'd just be that little bit more at risk. So that's our person who has come in for their first test. These are the likelihoods of the various outcomes for them. Okay, so what about the people who come back again in 12 months' time? So they were HPV positive on their first test. We've asked them to come back in 12 months. As Nóirín mentioned, we know that nearly 90% of people from what we've been able to track have returned within 15 months. Obviously, it will be really important for us to continue to track those people that were due to come back and see when they do return, or if, and obviously if they don't, it would be very important for us to figure out how we can support them to return. And while I'm chatting, I'd just be interested, for those of you who are listening in on the call, I'd just be really interested to hear of those of you working in primary care, how many of you would actively call people in using the practice software if they're HPV positive and it's come up to the 1 year since they were due to return. And I'm just wondering, do you send them a text message? Do you use your practice software to recall people when they are due to return for their 12-month repeat? So if you have an opportunity just to pop that into the chat, just to let us know, do you do that? Or if you don't, or some people sometimes use phone calls or letters. So just be very interesting from the program's perspective to know if people are getting an additional recall in addition to the letter that they'll get from CervicalCheck. So I'd appreciate that. Anyway, so those people who come back for their HPV test, they're 12 months later, hopefully, and what happens for them? So what we know is that 42% of them will have cleared their HPV, so they'll now be HPV negative at the 12-month repeat, and 60% of them will remain HPV positive. So again, we know that if they are HPV positive on their 12-month repeat, so on their second HPV test, regardless of whether the cytology is positive or negative, they're going to be seen at colposcopy. So they will be referred on to colposcopy regardless. But let's just see what actually does show up on their cytology. So 60% of them have remained HPV positive. But again, their cytology is, in the majority of cases, is showing no cytological abnormality. So 65% of them will have no cell changes visible on cytology. They will be still, as I mentioned, they will still be going to colposcopy for that kind of double check. But the majority of them will have no cell changes. So we know that they had HPV last year. They still have HPV this year. But actually, it hasn't made any changes to their cells. There is no sign of any abnormality when they have their cytology done. 30% of them will have low-grade cytological changes on their persistent HPV sample. So around about 1 in 3 of them, they didn't have any changes last year, but they've come this year and they do have some changes on their test. And then a smaller number, again, 4% of those women who've come back with, and we found them to be persistent HPV, but just 4% of them have high-grade changes. All of them will be checked in colposcopy, but I suppose just when you're looking at that kind of risk profile, when you're talking to people, what does it mean when I have HPV positive again? And it can be very frightening for people. You know, they can automatically assume sort of the worst, but hopefully what we're able to say to them is, yeah, we'll go and we'll double check it. You'll head off to colposcopy and be well looked after there. But actually your chances of having a high grade cell change or something that, you know, might be closer along the line of CIN1, CIN2, CIN3 that might be closer to the CIN2 and CIN3 end is actually quite low. So as I say, that's our kind of roundup of the data that we have from the last 2 years and what that might mean when we're talking with women when they come in. A couple of the other things I suppose that are you know, always interesting in the report when we look at it, and Nóirín has gone over these, but you know, looking at the age ranges. So these are the actual numbers of people who came in, and this is 21, 22. So we can see that the actual numbers of women sort of between 35 and 45, they're that's the greatest quantity of women, if you like, that we see coming into us. We see much fewer women over the age of 50, as Nóirín has mentioned. We see quite a number of women in the younger age group. So as soon as they become eligible, we know that Irish women do tend to come in, but this is where our biggest kind of population is. So again, these are by numbers. When we change that to coverage, so that's the numbers as a percentage of the number of women in that age group, if you know what I mean. So how many of the women that should come do come. And again, and I know Nóirín has covered this, but just kind of nice to sort of have a look at it, that we have this really excellent coverage rate in the 25 to 29s. It goes down a little bit here. I suppose some of the conversations that we have with people around that might mean that when people are having their babies, which we know that the average age of first delivery in Ireland is 31, and that tends to be a time that things might go a little bit by the wayside for people in terms of looking after themselves. But it comes back up again then in that age group, the 40 to 44 and the 45 to 49. And we see then this big decline afterwards. This number here is a little bit confusing because we only started offering screening to people over 60 in 2020 when we moved to HPV. So it's kind of hard to tell with that number. That's a little bit of an erroneous number, but it's very obvious here that we can see the decline in people over the age of 50. And we really want to try hard to work on getting that up. This is our 70% line that we want to achieve for achieving elimination. And this is the OECD average here. So you can just see, you know, we're good, but it's really important that we would work on this very obvious area here where there's a dip. Just for comparison, and not that we're ever very competitive with England, but I just find this one curious about the age ranges, is that they almost have the exact opposite slope than us, in that they have quite a low range in their younger age group. So now these are only categorized into two different age ranges. So the 25 to 49 is actually much lower then they're 50 to 64. So for whatever reason in England, it's a switch around from what we have in Ireland. So their younger women tend not to come and their older women do. So again, any thoughts on why that might be? Always very interesting to contemplate these things. The other thing that we're always can tend to be a little bit competitive is between counties. So like that, you might want to have a much closer look at your own county there to see where you're at. So this is our 70% line here. So again, the target that we really want to achieve in order to get to cervical cancer elimination. And we can see Carlo, as Nóirín mentioned already, Wicklow. Don't know why it helps to have an O at the end of your county, but it does. And then in between all of these little kinds of ups and downs. So these counties that are struggling, again, Nóirín mentioned how we're kind of trying to figure out why that might be. We've been trying to kind of cross it over with, is it to do with density of general practice? Is it to do with density of population? You know, what are the reasons? So we really need to work that out. But again, any thoughts, you know, if there are things within your own county that you feel, or within your own population that you serve, that you feel could be influencing people's attendance, please do let us know, because we would really like to work on supporting every woman in every county to be able to come for screening. And these are just, I suppose this is just in general information when talking with women around cervical cancer, because it is one of the cancers that we can screen for, and because obviously there has been an awful lot of talk about cervical cancer in Ireland, it can be very much at the top of people's mind and can be terrifying and scary for people. And we absolutely want to support people to make sure that people are always diagnosed at the earliest possible stage. We want to reduce the prevalence of cervical cancer in Ireland, which again is our motivation towards cervical cancer elimination. But as a percentage of the total number of cancers that are diagnosed in Ireland, you know, cervical cancer is at the lower end. So this is just more for those people who you might find who'd be coming in maybe very concerned about that change from HPV. And Nóirín very eloquently covered how a cytology program is actually less effective at finding early cell changes that may lead to cervical cancer, that a HPV program is more effective. But overall, in a person's overall scheme of things, while it's really important that they look after their health, look after their risk factors for cervical cancer, for those people who find that they get very overwhelmed by it, it can be useful just to say to them that actually, as a cancer, it is relatively rare. So I'm going to come out of that there. Now they were just my little snippets of things that I thought might be useful. And as if there are any questions that anybody has, or I'll go back over to Nóirín and see what you think.
Lovely graphics, Sarah. I suppose we might just get Rachel, Paula, Maeve, Mary make any comments or observations on the report or the data, anything, just while people are thinking. I don't know if there's any questions have come in, but just while people are getting their thoughts together, there's a lot in that. Anything you'd like to mention?
I just see, Nóirín, just somebody had responded when I had asked about how people recall women who would be due their second test, and somebody has just said that they put it into the tasks category, and a reminder comes up, and they call them, so that's a physical phone call. Okay. So thanks for that. And somebody else using Socrates recall for yearly smears. So again, that's using the practice management software. It is very straightforward and easy once you have it set up. You can do the bulk SMS messaging from it, and you know, we really would recommend as many people as possible exploring how their practice software can be used to recall. We really would be very interested in finding out how much is the effect of the communication from primary care in terms of encouraging people to come in, and then the combined use of the letters from CervicalCheck, just to see which is the kind of the motivational factor that brings people in for particularly for their second HPV test, their annual repeat.
Hi, Maeve here. Again, it's great to see that the HPV positive women, the majority of them are coming back within the 15 months. And obviously that's something we want to ensure continues. So again, just for primary care participants, when we do fail safe these women, and you do get them, if you can pop online and let us know that we have contacted the women, or let us know if they've moved out of the country. It just gives us that extra data so we can see that actually women who need to come back are coming back.
Yeah, that's an excellent point, Maeve, as well, in that we would very often fail safe, so follow up with people ourselves, and have it all followed up within our own practice software. Sometimes we might forget to let CervicalCheck know what we've done, so we've done it all, and in our heads the task is done, and we're clear that the woman is away for 6 months and she'll come back, and that's all fine. But it does help the program if we actually just let the program know, particularly when we're looking at stats and data, that we can kind of close off a few extra loops within the program to make the data more robust. So that's an excellent point, Maeve. Yeah,
absolutely, Maeve, because I kind of go from thinking that's great, 88% come, to panicking about the 12% that don't come. So that, yeah, so if that 12% actually was a bit lower, and that we could know that would be reassuring. Because I think that's one of our key messages we need to get out, is that screening works best if the process is followed. So you need to get the test when it's due, do the follow-up when that's due, all those fail-safing things all make the thing work. And I think maybe we don't really explain that as well as we could to women, the program, all of us together, that it's you kind of need all the bits. You can never say, oh, that's great, now I've had a normal test, I can forget about the whole process. You need to keep doing the follow-up till you get out the other side of it.
Yeah, absolutely. And it's worth saying what Maeve said there is, with the fail-safe, go on the CervicalCheck website and do it online. It's much more simpler than sending back a posted letter. So please do that online. And another thing is, when you're filling out the screening form, it just came to my attention today, is just to make sure you use the ear code. It's really important for the lab. So just some 2 little nuggets.
Very good. We've blinded you with data.
I don't think there's any more questions.
Yeah, no, I see, Rachel, you've put in the feedback link there in the chat. So like that, we're always very grateful for any bit of feedback that people can send in to us. Please do fill in our little survey. Be most appreciated.
Yeah, and actually, speaking about feedback, a lot of sample takers wanted a webinar just all about the laboratory. So we've got Dr. Ashton O'Connor facilitating our next webinar on the 20th of May. So if you haven't registered for it, I've put the link there in the chat function. So please register today. We'll send out a reminder anyway this week, prompting you to register, but it should be a great webinar. It's the first time actually we've done one in the lab, so I'm really looking forward to that.
Brilliant. All right, well, listen, thank you very much.
Sorry, Nóirín, just 2 seconds. If we have 2 seconds, there's just a couple of questions that had come in, and while we have the experts on board, that would be great if we can get it. So one question coming in relation to the accession number. So is the accession number necessary on referral to colposcopy, delay in getting referral form? So I think by accession number, does Irene mean, is that in relation to the result number? So I don't know, Paula, Mary, or Maeve, any one of you might know the answer to this.
Yeah, it is required. It's the lab accession number that identifies the screening test that warrants the referral. So it is an requirement, and the systems are built that way. It's mandatory on the system. So they can't process the referral without the lab accession number.
And again, so Paula, that accession number obviously comes in on the health link result.
Yes.
Just when this person mentions about getting the referral form, so our pre-filled referral form. Obviously, if you're still in an area that's using sort of manual or postal referrals, we do recommend that you're waiting for the pre-filled referral form. For somebody who might be in an area now that is accepting e-referrals, which would be certainly in Kerry, the accession number that comes in on the health link result can be used to fill into the result. Again, I'm familiar with Socrates, so that's what I'm talking about. So that's going to be going into the investigation section on the e-referral form, if I have that correctly. Does that sound right, Paula?
Yeah.
Okay, so it's just the result comes in without accession number on Health 1. So that is feedback there from somebody using Health 1. I think maybe that the thing with that is just sometimes they can be to do with the view of the result. It might be worth getting in touch with Health 1 just in relation to that. Sometimes it's hidden in a separate section, if you know what I mean. So the basic result might come up as one thing, but there might be a way of finding the accession number. It might be just worth checking with Health One around that, is what I would say to that person who's asking that. And then just another question in relation to the responsible doctor. Has this to be the GP lead only? So the clinically responsible doctor is the person within the practice, the doctor within the practice who has signed a contract with CervicalCheck. There may be more than one person within the practice who signed a contract with CervicalCheck. So within a multi-doctor practice, there may be, 2 or 3 doctors who have a contract with CervicalCheck. So just making sure that the clinically responsible doctor for that patient is a person who has signed a contract with CervicalCheck. Some practices find it more useful to have a single clinically responsible doctor, depending on their setup, but then that is the person who is always the person on the form. And certainly, again, that can be something if you're using your software to fill in the referral form, just making sure that it only allows you to put in the people who have a contract with CervicalCheck. I think I have that
just to add to
right,
that,
Rachel?
Sarah, yeah, just to add to that, really one important thing is if you have a number of sample takers, they need to be registered under each CRD. So if you said if you're in a multi-GP practice, you've got 3 different GPs that hold a contract under CervicalCheck, I, as a sample taker, need to register under each one individually. So that requires 3 separate forms, which is, I know it's a lot of paperwork, but it needs to be done because if that's not correct, it does actually cause trouble on the other end for us in CervicalCheck. So to make it easier for yourself, if you log into NSS Resources or e-learning portal, we have that clearly explained. How would you register as a sample taker? You can download whatever forms, you can sign it, you fill out the form as a sample taker and you get your clinical responsible doctor to sign it. So it's very simple, and then you email it back to admin. Yeah, but it's really important you do it correctly.
Sorry, can I just mention one thing that we might have a couple of GPs on here as well, just to know, Sarah, you mentioned the e-referral, that the GPs in Kerry, Dundalk, Wexford and in the catchment area of Rotunda cease using the paper copies and use the electronic referral.
Yeah, so it's fantastic news that Kerry, Wexford and Rotunda, and sorry, Paula, was there another one there that I missed?
Wexford just went live on Friday.
Yeah, so that is fantastic news that you can now use the electronic referral for colposcopy. So the GPs in those catchment areas, Rotunda, Wexford and Kerry, if you go into the hospital drop down, find colposcopy and use your electronic referral that way, and then you will not need to use the paper referral from then, which is great. Obviously, we're aiming to roll that out to all 15 units nationwide, but you're the first, so get using them, and hopefully then we'll be able to eliminate the paper use, which will be fantastic from all sorts of perspectives. So that's great. I'd say we're probably done, Rachel, are we? Our tendency to end up cramming things in at the end, but always delighted to have a few questions coming in at the end.
We're delighted. Look, thank you so much for everybody for coming on board today. We've had a big team effort today with our webinar, so thanks so much. And thank you for you who have joined us. I know it's your lunchtime and you're busy probably trying to clean up and get back to your clinic. So thanks again for joining. And we look forward to seeing you all hopefully on the 20th of this month. Okay, take care.
Bye.
Yeah, bye.